Continuing now with slide number 12, we're moving on to obsessive compulsive disorder. As I said in the last little bit of lecture earlier, obsessive compulsive disorder has long been viewed, for the bulk of its history, as being a category of anxiety disorders. And there's a lot of compelling reason. There are a lot of compelling reasons as to why that's the case. For one, a person with obsessive compulsive disorder exhibits the classic conflicted, kind of paralyzed kind of lifestyle that you see in a lot of anxious people. Obsessive compulsive people tend to be very anxious in their presentation. They tend to have a lot of tension in their lives. But little by little, the tide has shifted, culminating several years ago in the publication of the DSM-5, in which obsessive compulsive disorders were moved into an entirely different section of the DSM. The reason for that is that the brain structures, the brain systems involved in obsessive compulsive disorder tend to be very specific and very distinct from the other anxiety disorders. And so because neurologically it's seen as being very distinct, even though there is some degree of overlap in terms of symptomatic presentation, it's largely seen as something quite different. First and foremost, we need to understand that obsessive compulsive disorder is a chronic psychiatric condition, and treating it medically is completely essential. It's different from other anxiety disorders where therapeutic treatment may not only be essential, but overwhelmingly the treatment of choice. With OCD, medication is almost always going to be a part of the treatment program. So if you know someone who's suffering from obsessive compulsive disorder, if one of your patients has obsessive compulsive disorder, it is really essential that they get some sort of medication evaluation, that they undergo some sort of psychiatric evaluation, because it's such a different kind of disorder. Incidentally, knowing that will help you explain how it's different to your patients. If they can see it as being something that is categorically different from anxiety, that can often help people who are reluctant to consider taking a psychotropic medication. It can help them to actually get on them, and for them it can be very, very helpful. A couple of other things about OCD: very few people with OCD get appropriate levels of help. One of the reasons why they don't get a lot of help is that OCD has its own kind of reinforcement schedule that keeps people locked into the OCD mindset and makes it very difficult for them to get out of it. For example, if I'm anxious about something, but there's something that I can do that gets rid of my anxiety, I'm going to do that again and again, and it may not occur to me that I have a problem because I can solve my problem seemingly so quickly. Of course, the problem is that it's very chronic and that it repeats itself, and then it starts taking me away from my main activities in life. And of course, and this is the big similarity that OCD has with anxiety disorders, is that people with OCD and people with anxiety disorders are hardly getting anything done at all. A stressed out person may not be living a very healthy lifestyle, but they tend to be very motivated. They tend to get a lot of things done. Anxious people tend to get very little done. There's lots of hand-wringing, lots of paralysis, basically a lot of inertia. Same thing with obsessive compulsive disorder. Other thing you need to know, OCD is notoriously difficult to treat. Despite the fact that there are treatment options available, despite the fact that they do respond to therapy, it is a tough condition to treat. And so that's very helpful for you to know that going in, especially if you're the kind of therapist that enjoys working with people who have anxiety, because it does feel so good when you see a person turn their life around, but they start to get better. It gives you the best feeling as a therapist to know that a person is responding well to treatment. But with OCD, you're going to have patients who show some degree of progress, then they're going to go back to their old ways. The symptoms are going to repeat themselves. And so it's a bit of a challenge, and it can drive therapists a little nutty if they're not really, really patient, if they don't understand that it is a long-term treatment regimen that's required. 67%, two-thirds of patients diagnosed with OCD are concerned with dirt, germs, filth, and then have some sort of corresponding cleaning or undoing kind of compulsion. They worry about dirt, so then they have a compulsion about cleaning. They're afraid of germs and filth, and they become obsessed with making sure that things are sterilized or sanitized or washed or just having been purified. Um, Very interestingly, because we're living in this COVID-19 era and people are going around trying to buy all sorts of hand sanitizer, hand soap, face masks, we're trying to do everything we can to avoid contact with infectious germs. Um, People who have OCD are experiencing a bit of a strange time right now because the world is in a way acting more like how they typically act, and people are finally behaving in ways that a lot of people with OCD already behave. So now you have people washing their hands all the time. Well, OCD people wash their hands all the time. They were doing that already. So very interestingly, and paradoxically, you may have already noticed this, that a lot of people who have OCD and a lot of people who have anxiety actually are doing kind of okay during this crisis. Not all of them are, but a surprisingly large number of people actually fare pretty well during these types of crises. 20% of OCD sufferers are concerned with danger and therefore have checking compulsion. So remember, with obsessive compulsive disorder, just as a reminder, people suffer from having obsessions, which are intrusive thoughts that increase anxiety. That's what an obsession is. It's a thought that, without our control, enters into our field of vision, so to speak. We start thinking about it. We start worrying about it. We obsess about it. That's hence its name. And that raises our anxiety levels. Compulsions are the behaviors that we feel compelled to do in order to get rid of those anxious feelings that come from the obsessive thoughts. And so the compulsions, that's the more visible part of the disorder. The obsession, that's the invisible part of the disorder. The compulsion, that's usually what we see an OCD person doing, and that's what usually leads to the diagnosis. 10 to 15% of people with OCD are concerned with orderliness, symmetry, and have perfectionistic compulsions. So what's really interesting is that in pop psychology terms, or when you hear people just in their everyday discourse, you might hear some people say things like, hey, I have OCD, I like to have everything lined up, or I like to straighten things out, or if there's a spot on my car, I like to wipe that spot off and make sure that everything is perfectly clean. Well, the problem with that is that only describes a very small percentage of people who have OCD. Remember, 2/3 of people are mainly preoccupied with uncleanliness and trying to keep things that are dirty clean. Only about 10 to 15% are people that look like the OCD people you see in movies, that keep everything in perfect order or are preoccupied with symmetry, balance, and things like that, and have those perfectionistic compulsions. Moving on to slide number 13, continuing with OCD. People with OCD have profound, excessive self-doubt and concern about their own safety and the safety of others. It's not unusual at all for moms who didn't have OCD tendencies before to then have children and then develop OCD tendencies about protecting their children from harm, real or imaginary. They may become preoccupied with feelings of needing to be safe, preventing things that could harm them for getting a hold of them or their families. So there's a lot of concern about safety. I think I told you in class about one patient that I had who had an extreme high amount of fear for her parents' well-being. There's a young girl that I had treated many years ago. She just had tremendously high levels of anxiety because of fear for her parents. She didn't have a lot of fear about herself, but when she ever met someone that she loved, like a best friend, or if she had a relative that she cared about a great deal, like her mother or her father, she was less afraid of herself, but she was very afraid of the well-being of her mom and dad or her siblings. Okay, 2/3 of obsessive compulsive sufferers become clinically depressed, which is very interesting because I think that there's something about maybe they're not naturally inclined toward depression, but when you live an OCD lifestyle, you tend to not get a lot of things done. You're always covering your tracks and you're always losing a lot of time engaging in the compulsive behavior so that you become very inefficient and consequently you miss out on a lot of things that life has to offer. So oftentimes you're not there for the people in your lives, even though you may love them very much. So in this situation, people with OCD often become depressed in the classic sense of depression, which is they are experiencing some sort of loss, not necessarily because of a biological depression. A bit of differential diagnosis. OCD is people experience OCD as being more painfully under attack from their obsessions, whereas the personality disorder called OCPD tends to be egosyntonic. Egosyntonic just means consistent with the kind of person that they are, meaning that with OCPD, obsessive compulsive personality disorder, people tend to be perfectionistic because that's the kind of personality they are. They're the kind of people that tend to be very insistent upon things being a certain way. They're just very particular. And in that case, it resembles more of neurotic anxiety than someone with a classic case of OCD, in which a person has many, many, many obsessions that feel like they kind of attack them. And then their compulsions are absolutely they must be adhered to and they must be done. Whereas someone with OCPD is not as driven by their compulsive behaviors. They're still compulsive, but they're compulsive as a matter of preference, not because they are more or less enslaved to the compulsive behavior. And that's the main thing, is that people with OCD act as if they are kind of enslaved to this pattern of behavior. It's extremely, extremely rigid. One other bit of differential diagnosis is that you will see an obsessive compulsive pattern in patients with anorexia nervosa, the eating disorder. One of the differences, though, is that people who are anorectic tend to have less insight as to the appropriateness of their obsessions, and they don't tend to respond as well to medicines and medications designed to treat OCD. So it appears to be a slightly different brain dysfunction with anorexia than with classic OCD. Although if you do notice some similarities, you are paying attention. People with anorexia nervosa tend to have an obsessive compulsive type of pattern. You also see this a little bit in people with bulimia, in that when they ingest a lot of food, their anxiety goes up, and then on the binge side of bulimia, and then on the purge side of bulimia, the purging lowers their anxiety a great deal. And similarly, there is a lot of depression in eating disordered patients. Continuing now on slide number 14, the etiology of OCD, it is now, as we've said before, recognized as being more biological. The evidence is that with OCD, there is a much more predictable, stable course, whereas in other psychological disorders or psychiatric disorders that tend to be that tend to be more psychogenic in their orientation, the brain responses are a little bit less consistent. There's also a strong degree of heritability and inheritance with OCD, with first-degree relatives. The chances of getting, if a first-degree relative has OCD, the chances of that person's relative having OCD are very high. We also know that with OCD, they do really well with SSRIs, but as opposed to panic disorder, the anxiety disorder side of things, which does really, really well with tricyclics and MAO inhibitors, with OCD, it does not do well with those other antidepressants. It only does well with SSRIs. OCD also is associated with increased activity in the prefrontal cortex and basal ganglia, which resumes to normalcy when a person is on SSRIs. Now think about that. That makes a lot of sense when you stop and think about it. Your prefrontal cortex is the area where you're doing a lot of executive functioning. You're doing lots of planning. You're engaging in lots of judgment. You're engaging in lots of problem solving. You're thinking. You're analyzing. And that's so classic and so typical of an OCD person. They're constantly tinkering with things. They're constantly planning. They're constantly trying to figure out what's going to go on with their day, but to a detrimental extent. It's too much. And so taking the SSRI gets that prefrontal cortex back to normal working conditions. Some explanations that are helpful, and both of these account for the success of SSRIs. First is the disinhibition of the frontal lobes, which normally block the primitive urges, and the nonstop danger and arousal feedback loop that fails to shut off. So SSRIs and their effectiveness with treating OCD can be seen in some of these in these two explanations. Again, disinhibition of the frontal lobes, which normally blocks our more primitive urges, and that nonstop danger / arousal feedback loop that fails to shut off in patients with OCD, but when you take the SSRI drug, it tends to work a lot better. For treatment of OCD, as we've said before, therapy is often very ineffective. It does work. I'm not going to say that it's ineffective. I've experienced a lot of success on the therapeutic side with my OCD patients, but it's often, in comparison with the medication, it often doesn't work as well. So that's just one thing to brace yourself for. Don't think that you're a bad therapist. Don't think that you're not doing a very good job, or that you're not making inroads, or that your work with your patients is not meaningful in some way. It's just that because it is so powerfully part of a person's neurological profile, don't beat yourself up if you aren't making the kind of progress you do with your other more anxious patients. Effective interventions for OCD. Remember, SSRIs are the main treatment of choice with OCD, in combination with therapy that focuses on exposure and response prevention. What we mean by ERP, exposure and response prevention, is any kind of therapy where you are exposing a person to an anxiety-provoking situation, but you're preventing them from being able to engage in the dysfunctional response. So in this case, you're preventing the ritualistic behavior, and you're forcing the patient to deal with the crippling anxiety of not performing some sort of compulsive act. And again, it's very challenging, it's very trying, it can be very upsetting for a patient when you don't give the patient the opportunity to engage in that compulsive behavior. But over time, they begin to realize that it will not hurt them to not engage in that compulsive behavior. There is a 75 to 80% effectiveness rate for the treatment of OCD, but only after about 20 to 25 sessions. In today's parlance, that is a lot of sessions, as the name of the game today tends to be more time-limited therapy. SSRIs counteract the depressive and OCD symptoms directly, so that's another good part of the SSRI profile. Typically, it will involve a higher dosage. So if you do see your patients with SSRI drugs who have OCD, those SSRI drugs will usually be prescribed in a higher number of milligrams. They're not perfect. The treatment for OCD is not perfect. The drugs work in about 50 to 65% of cases, with a 50 to 60% reduction in symptoms. Now, that may not sound very encouraging, but if you're talking about someone in the throes of severe OCD, that is pretty darn close to a miracle. A 50 to 65% number of cases are successfully treated. There's a bit of a range there, but even anything over 50% with OCD is a great response. We do know that after a person goes off the medication, there is a 95% relapse rate. So that's extremely, extremely high. So part of your psychoeducation for your patients is getting them to understand that being on the medication is probably going to be part of their lives for many, many years to come. They will not want to hear that, but unfortunately, it's the truth. Now, one good part about it is that if you have patients who are afraid of becoming addicted to the medication, remember that with SSRIs, there's not a risk of addiction. So that's very helpful. Moving now down to benzodiazepine drugs. We're not now going to be talking about the drugs a little bit more specifically. Benzodiazepine drugs were first developed in the 1950s. The first was Librium. That's the trade name. The generic name, chlordiazepoxide. Again, that's 1957. So Librium was often used in a lot of psychiatric facilities from the 1950s all the way up to the 1980s and 90s. It's used to treat anxiety and acts as a sedative, and it also acts as a hypnotic to induce sleepiness in insomniac patients. Remember, anxiety and insomnia often go hand in hand, particularly with what we call primary insomnia. Primary insomnia refers to a person having a very difficult time falling asleep. Secondary insomnia has to do with a person who can't stay asleep and wakes up frequently in the middle of the night. And tertiary insomnia is insomnia that is associated with waking up before you want to and staying awake for the rest of the day. So if you normally get up at, say, 7 a.m., you're finding yourself sometimes getting up at 4 a.m. or something like that. In addition to primary, secondary, and tertiary, you will see that name, those names also called primary, middle, and late. But primary is used in either way. Most benzodiazepines typically act about the same way. Most people are not taking Librium anymore. Most people are much more likely to take Xanax, especially patients with anxiety disorders and panic disorders especially, or people who are having panic attacks. You'll also see a lot of Valium being prescribed. They're very fast-acting and very effective at lowering a person's anxiety, which is why they're so popular. They're also tolerated reasonably well, even though it does act as a sedative and can cause a person to fall asleep. They often don't get very groggy when they take them. They might at first, but they tend to tolerate them pretty well. And one bit of good news about benzodiazepine drugs is that they are far less addicting and far less lethal than the barbiturate class drugs, which were prescribed in heavy amounts in previous years and were associated and still have been associated with some pretty high-level overdoses that have killed a lot of famous people, particularly actors and actresses and musicians who would get prescribed these high-level, high-dosage, what were back then, like 1950s, 60s, and 70s called sleeping pills. But they were really just barbiturate class drugs, and they were really dangerous. Benzodiazepine drugs interact with benzo and GABA receptors in the brain, especially in the limbic system. So in that area of the brain that's responsible for fear, that's where the amygdala is, and it causes a person to not be as afraid as they used to be. It can kind of give them a sense of courage. It can give them a sense of reassurance that things are going to be okay. They have very short half-lives, which means they get metabolized by the digestive system very quickly. But even though they have very short half-lives, they do tend to build up in the body, even in low or once daily doses. They are metabolized by the liver, so it's very important that the liver is healthy. And this is one of the other reasons why you cannot mix benzodiazepine drugs with alcohol, because that's also metabolized by the liver. And if you're gonna take two drugs that are both metabolized by the liver, remember, one drug always wins and one drug loses. It's not like it does a little bit of both. The liver will choose one to metabolize and then not the other, which increases toxicity dramatically in the body. There are atypical anti-anxiety medications. We already talked about the most famous one, which is Buspar/busoprone. So that's getting down here now to slide number 18. But other ones include Ambien, Sonata, and Lunesta. These are short-acting, non-benzodiazepine drugs used for sleep. So many of you have heard of Ambien. Ambien is often given to people who would like to be able to sleep on an airplane, but they can't, and so doctors will often prescribe these. You'll see a lot of people on airplane popping those Ambien pills. It doesn't interfere with REM sleep or deep sleep. However, it's very important that you know this because so many people do take Ambien, and that is that there is recent evidence suggesting that women should only take half the dosage of Ambien that they normally take. And remember, we talked about this in class, that a lot of the drugs that are tested on people are only tested on men and not women, because women often can become pregnant. And if a woman becomes pregnant while she's doing a medication trial, she will have to be dismissed from the study, and then you can't use her data. So a lot of these drug companies, when they're doing these trials or other independent agents who are doing these drug trials, they will only have men. And so when they publish the data on Ambien, they published it was only based on men. And in this case, that turned out to not be a very good thing, because women were taking the suggested dosage at the dosage rate that was normally given to a male. And as it turns out, that was not so safe for women to take at that high level of amount of the pill. So women should only take half the amount that men take in Ambien. So we already talked about Buspar and Busoprone. It has a delayed onset, And so you're going to get a reduction of anxiety usually in a week or two. So it kind of comes on at the same rate as an antidepressant, usually around 7 to 10 days is when an antidepressant, if it's going to be effective, is going to start to be effective. Remember too that side effects usually precede the normal treatment effects that you're going after in a drug. Remember, like in the case of an antidepressant medication, the side effects are usually going to be visible the first 7 to 10 days, and that often interferes with a person staying on the drug. They might say things like, I didn't like the drug, I hated the drug, it didn't work, I didn't feel any better when I took the drug. But it's really important to get people to try to take it as much as possible for that full 7 to 10 days or even 14 days. And a lot of the side effects that people feel initially do eventually go away. Now, some of them are truly unbearable, so in that case, it's important to get them off the medication because it might just be dangerous or just incredibly unbearable. But remember, for a lot of people, those side effects do go away, and it could have been a good medication for them, but they didn't stick with it. So that's an important thing to remember as well. Same for Boost Bar. There doesn't tend to be as many feelings of tolerance, dependency, addiction, and with Boost Bar, and it doesn't interfere with other central nervous system depressants, aka alcohol. So it's a good drug to be able to take if someone is already drinking a little bit. Boost Bar, remember, is not always effective, and it could have some side effects, including nausea, dizziness, and paradoxically, and I put a little exclamation mark by this one on the last bullet point there, anxiety. The very thing you don't want, the very reason why you're taking the drug in the first place is to decrease your levels of anxiety. Sometimes people who take Boost Bar find themselves even more anxious than they were before. A little note down there at the bottom, Sonata has the shortest half-life of any of the non-benzodiazepine drugs. It's only a half an hour. So Sonata works very, very quickly. Okay, moving on to number 19. Other anxiolytic medications include antihistamines, for example, Benadryl, which block histamine receptors in the central nervous system, which causes sedation. They are non-habit forming, but tolerance does build quickly for the anxiolytic qualities that antihistamines do have. So it tends to not work you tend to need to take more and more to get the same effect. There's also a very, very narrow therapeutic window between sedation on the one hand, which might be what you want, versus drowsiness on the other hand, which is going to make you very unhappy if you have to stay awake and work during the day. We already talked about beta blockers. Probably the most common form of beta blocker is Inderal, which blocks norepinephrine at the site of the receptor, and it's used to treat performance anxiety. You may have some relatives that take beta blockers not because they have performance anxiety, but because they have high blood pressure. Beta blockers do reduce blood pressure. If you're going to take benzodiazepine drugs, what's usually advised is to try therapy and relaxation techniques first. If that is not effective and a person is very interested in going on the benzodiazepine drug, then it's usually best to encourage them to focus on a 6-month treatment window to say, look, let's try this for 6 months. If it's not working after 6 months, let's discontinue. Even if it is working after 6 months, we still want to try to discontinue. You don't want a person taking benzodiazepine drugs chronically for years and years. And this is especially the case if a person has a drug abuse history. You also have to watch out, too, in case a person is suicidal, because if they overdose on benzodiazepine drugs, it can be fatal. Just know, though, that there are some people that do take benzodiazepine drugs for years and are more or less fine. So again, it has to be evaluated on a case-by-case basis. For people who do take benzodiazepine drugs for many, many years, the disorder that tends to work best for it, if you're going to take it for a long period of time, is panic disorder. But the other disorders, that doesn't tend to go very well for people who take benzodiazepine drugs for years and years. And the use of benzodiazepine drugs to this day remains very, very controversial. We do want to go lastly over some of the symptoms of withdrawal. If a person is withdrawing from benzodiazepine, they can experience restlessness, insomnia, nightmares, anxiety, seizures, high fever, psychosis, and even death. So it's a very, very serious issue to suddenly cessate benzodiazepine drugs. As a general rule, when you're going through withdrawal from any drug, it's usually going to produce the very opposite symptoms or the very opposite effects that you took the drug for in the first place. So if you took the drug to treat your anxiety, withdrawal is going to look like anxiety, restlessness, agitation, the very thing you don't want. Withdrawal syndrome exists because of the very short half-life that the drugs have. They exit very quickly. When the symptoms of withdrawal last longer than 2 weeks, it's probably not pertaining to the drug. It's probably a return of the anxiety that the person had in the first place and is no longer part of that withdrawal syndrome. So earlier when I said that when you stop taking benzodiazepine drugs, the anxiety usually comes back stronger than ever, that's what that is. It's probably no longer the medication cessation that's at work. It's probably the anxiety coming back. So the best approach when you're getting off of benzodiazepine withdrawal is a gradual withdrawal. Always, always have your patients contact their doctor if they're planning on getting off their benzodiazepine medication. That's not something that you should be telling them to do directly. It's very unethical for a psychologist to be giving any kind of medical advice. Always refer to your therapist. It's just that when you do hear of someone going off of a medication, or if you do hear of someone doing something that could be very dangerous to them, mention that that might be dangerous and that they should go talk to their doctor. So it's helpful for you to know what the red flags are and when they should go contact their doctor. Always encourage them to follow doctor's orders. So go off the drug very gradually. Watch out for patient resistance, especially there it is again to eliminating that last dosage. That can be the hardest one. And hey, if it's not hurting anybody, have them hold on to a small amount of it. I have no problem with that. Hope you enjoyed it. Take care. Talk to you soon.